Hello and good evening all. We are going to commence the lecture on colorectal cancer, and we are going to divide the lectures into different parts so that this topic can be discussed extensively. Because colorectal cancer is becoming a common condition, not only affecting the developed world, is also trending among developing countries. So today we are going to talk about the epidemiology of colonic cancer, anatomy, risk factors, as well as the pathology of colon cancer. So by way of introduction, you should know that colorectal cancer is the third commonest malignancy after cancer of the lungs and stomach in males, and after breast and cervical cancers in females. So you should know that colorectal cancer is the third commonest malignancy affecting both sexes. Now, it accounts for 10% of cancers in males, 9.4% in females. And the cancer mortality is about 8%. You can see it's generally commoner in males, okay? However, you can see rectal cancer tend to show more frequency in males, while colon cancer tend to show more in females. But all in all, they are commoner in males as compared to females. Worldwide incidence is 1.2 million annually. And you can see up to half of all these patients die from the disease. So it's of public health importance. You can see this large amount of annual incidence, which about half of this patient will die. And you should know about 30% of these patients at presentation, they already have metastasis. It has already spread commonly to the liver. Now, at presentation, you should know that 30% of patients with colon cancer have metastasis to the liver. So it's a disease that is worrisome and can be very aggressive and difficult to treat when a patient presents in an advanced stage. You should know in the Western world, it is next to only bronchogenic carcinoma. Now, within the colon, about 50% of cancers arise in the left side and 25% in the right side. Now, this is very important for you to know because most of the left-sided colon cancer presents with obstructive symptoms. They present with features of intestinal obstruction, while those on the right side present with features of the 3 A's of malignancy: anemia, anorexia, and asthenia. While on the left side, which account for up to 50% of this, they present with obstruction. Now, you should know that in Africans, the incidence is increasing due to urbanization, even though the overall incidence in Africans is low as compared to the Western world. Why is the incidence lower in Africans as compared to the Western world? These are the three main reasons why colon cancers tend to show a lesser frequency in Africans than in the Western world. Now, it is attributed to the young age of the population in Africans, because colon cancer is a disease that is seen in the 6th and 7th decade of life. The older the population, the higher the risk of that condition in such population. Now, in the Western world, they have longer lifespan. They tend to reach a more older age than in the developing countries that tend to have a shorter lifespan. So the frequency is lesser in developing countries than the developed world. Now, our diets. Most of our diet is high fiber diet. So the transit time, okay, of feces and fiber diet. So when you have high fiber diet, the transit time of stool in the colon will be shorter. And the shorter the transit time, the lower the risk for colorectal cancer. While if you look at the Western world, their diet has less fiber and it has higher transit time. With higher transit time, the contact of feces in the colon as well as the carcinogens that are produced is longer. Hence, they have a higher risk. Now, rarity of precancerous conditions. There are some precancerous conditions which we will see shortly. These conditions tend to be commoner in the Western world compared to African population. Hence, we have a lesser frequency of colorectal cancer. Now, we are going to discuss briefly relevant anatomy of the colon and rectum, because this is very important for understanding the disease as we go further, as well as the treatment of the condition. Anatomy is a very important aspect for you to understand, to appreciate the presentation of colon cancer as well as the treatment for colon cancer. Now, the large intestine, okay, what is the extent? It starts at the ileocecal junction and extends to the anus. Now, this ileocecal junction at the cecum and ends at the anus, okay? So, the length of the colon is about 125 to 150 centimeters long and can be divided into the cecum with the appendix, the ascending colon, the transverse colon, descending colon, sigmoid colon, and the rectum. These are the various parts of the large intestine. Okay. we'll see in an image, of course. If you look at this, this is where it starts, okay? This is the cecum and the appendix, ascending colon, transverse colon, descending colon, sigmoid, and the rectum. This is the anus, the anal canal. Now, this part is called the hepatic flexure of the colon. This part is called the splenic flexure of the colon. Okay, so these are the various parts that makes up the large intestine. The length is about 150 cm, extending from the cecum up to the anal canal. Okay, even though up to the rectum, the anal canal is regarded as a separate entity. Now, what is the blood supply of the large intestine? The arterial blood supply to the colon comes from the superior mesenteric artery and the inferior mesenteric arteries. These arteries are branches from the abdominal aorta. These arteries, they communicate at the part of the colon that is called watershed areas. At the point where these arteries anastomose, the blood supply at that part is precarious, and it's easily, okay, it can easily undergo colitis, ischemia, and when anastomosis are done at that point, they are very critical. Now, let's look at these arteries briefly. We have the superior mesenteric artery, okay? The inferior mesenteric artery, if this is the colon. The branches that supplies the right side of the colon comes from the superior mesenteric artery. The branches that supplies the left colon comes from the inferior mesenteric artery. What are these branches? There is the ileocholic artery. This ileocholic artery supplies the terminal ileum, the cecum and appendix, and part of the ascending colon. There is the right colic artery. The right colic artery supplies the ascending colon up to the proximal 1/3 of the transverse colon. So it goes up like this, okay? So we've seen two branches from the superior mesenteric artery, the ileocholic artery, the right colic artery, and the middle colic artery. The middle colic artery supplies the transverse colon. It has two branches, the right branch as well as the left branch. So you can see how these branches are forming close to the margin of the large intestine. On the left side, however, the branches from the inferior mesenteric artery are the left colic artery. The left colic artery. This left colic artery has an ascending branch that anastomoses with the left branch of the middle colic artery. I told you the middle colic artery is a branch from the superior mesenteric artery. It has a right branch and a left branch. Now, the left branch is anastomosing at the splenic flexure with the ascending branch of the left colic artery. And at that point, the blood supply is precarious. So it is a watershed area. It is called the critical point of Griffith. Now, the left colic artery also have a descending branch, okay? Supplying the left side of the descending colon. Now, the inferior mesenteric artery also supplies the sigmoid colon. There are sigmoidal arteries that arise from the inferior mesenteric artery to supply the sigmoid colon. There is a branch, the last sigmoidal artery coming from the inferior mesenteric artery, anastomoses with a branch of the superior rectal artery. Now, that point is called the critical point of Sudeck. It's also a watershed area. The critical point of Sudeck. So we've seen two critical points on the large intestine. The critical point of Griffith and the critical point of Sudeck. The anastomosis there is precarious. All these are important because of the treatment when you are doing surgery. The inferior mesenteric artery ends as superior rectal artery. So these are the arterial supply of the colon. Let's go back to the slide. The blood supply, the arterial supply to the colon comes from superior mesenteric artery and the inferior mesenteric artery, which communicates in a watershed area in the splenic flexure, the Griffith critical point. Now, the marginal artery of Drohnemond. The marginal artery of Drohnemond is arterial cycle or an arterial arcade that is formed along the inner border of the colon from anastomosis of the terminal branches of superior and inferior mesenteric artery. Now, if you look at the diagram we drew, you can see all these branches form an arcade just at the margin, inner margin of the colon. So this is termed, okay, the marginal artery of Drohnemond. Okay, it is an arterial arcade that is formed in the inner border of the large intestine that arises from the anastomosis of all the branches of the superior and the inferior mesenteric artery. And you should know it is not in all patients this arcade is complete. Now, you should know the marginal artery of Drohnemond, as we said, arterial cycle formed along the inner border of the colon from anastomosis of the terminal branches of the superior and inferior mesenteric arteries. This arcade is complete in only 15 to 20% of people. Now, there are some important features we'll discuss regarding this arterial supply. We've talked about the marginal artery of Drummond, the critical point of Sudeck critical point, the critical point of Griffith, and there's one more, the arc of Riolan. The arc of Riolan. Now, this arc of Riolan is a collateral artery that joins the superior and inferior mesenteric arteries. In case there is blockage of any of these vessels, there can be a collateral flow through the arc of Riolan to prevent ischemia. As we mentioned, the ileocolic, right colic, middle colic arteries, which are branches of the superior mesenteric artery, supply the colon from cecum to the splenic flexure. The left colic, sigmoid, superior rectal arteries, which are branches of the inferior mesenteric artery, supply descending and sigmoid colon. An inconsistent arterial anastomosis formed between superior and inferior mesenteric arteries is called arc of Rioland. Okay, it is also called mesenteric meandering artery of Moskowitz. It's an important collateral, okay, in occlusion. So these are very important anatomy that you should all know for you to appreciate colon and rectal cancer later on as we talk about them. Now, you should know beside the superior rectal artery, the rectum has additional branches from inferior, okay, from the internal iliac vessels. The middle rectal arteries arise from the internal iliac arteries and supply the distal rectum and upper anal canal. The inferior rectal arteries, branches of the internal pudendal arteries, crosses the ischiorectal fossa to supply the anal sphincter. We talked about the Sudeck critical point at the rectosigmoid junction. The last sigmoid arterial branch of the inferior mesenteric artery, okay, it usually forms an anastomosis with a branch of the superior rectal artery. The anastomosis is small and often only singular, and it's a watershed area. However, if you compare the watershed area of this and that of the splenic flexure, the splenic flexure has tendency for more necrosis than the one of the Sudeck critical point. Now, the venous drainage. The venous drainage of the colon usually is from the superior mesenteric vein as well as the inferior mesenteric vein. You should know that the inferior mesenteric vein, it unites with the splenic vein, okay? And this superior mesenteric vein unites with this splenic vein to form the portal vein, which is behind the neck of the pancreas, okay? Which is behind the neck of the pancreas. The venous drainage occurs into superior mesenteric vein, which joins the splenic vein to form portal vein. The inferior mesenteric vein drains into the splenic vein. Now, it is also important for you to know that the mucosa contains no lymph channel, so mucosa cancer rarely metastasizes. So what is the lymphatic drainage of the colon? Now, this is very important also for colonic cancer because of the treatment. You should know that the lymphatic drainage and the lymph nodes are in categories in the large bowel. There are lymph nodes that are in direct contact with the wall of the colon. There are those that are by the sides, those that are along the vessels, the arteries that supply the colon, and those that are the main point where the arteries originate from the abdominal aorta. So the epicolic group of lymph nodes are those that are located in the colonic wall. The paracolic are located along the inner margin, okay? Then the intermediate group of lymph nodes are located near the mesenteric vessels, along those branches, the superior and the inferior mesenteric artery. Then the principal group of lymph nodes are called the main group of lymph nodes. They are located where these arteries take their branch. If you look at this diagram, you will see the epicolic group of lymph nodes are these that are directly on the colon. You have the paracolic group of lymph nodes, the ones that are just by the side of the colon, okay? They are the intermediate group of lymph nodes, the ones that are along the branches of these superior and inferior mesenteric arteries. Then the principal group of lymph nodes are the main group of lymph nodes that are para-aortic at the junction of origin of these major arteries. Now, later we'll refer to all this anatomy during the treatment so that you understand the principles behind the treatment. So now we'll move on to the risk factors for colon and rectal cancers. Now, what are the risk factors for colon and rectal cancers? You should note there are various risk factors. Number one, the precancerous condition. At the introduction, we mentioned that colon cancer is less common in Africans as compared to the Western world. And one of the reasons we gave is the precancerous conditions are rarer in Blacks, in the Africans, as compared to the Caucasians in the Western world. The precancerous conditions are commoner among their population. These precancerous conditions are adenomas, polyposis syndromes, inflammatory bowel diseases, which we'll see and talk about them in detail shortly. Hereditary non-polyposis colorectal cancer. This is a hereditary risk factor for colon and rectal cancer, and we'll discuss that in detail. Dietary factors. Radiation, exposure to radiation, especially therapeutic radiation for treating prostate cancer, may pose a risk for developing colorectal cancers precisely. Alcohol and cigarette smoking, previous surgeries like cholecystectomy, ileal resection, ureterosigmoidostomy. And in about 85 to 90%, they just occur randomly, sporadically, without a known risk factor in these patients. Now we'll start by discussing precancerous conditions. Precancerous conditions, number one, adenoma. Adenomas are benign tumors that arise from glandular tissues. Benign tumors arising from glands are called adenomas. Now, these adenomas could either be conventional adenomas or serrated adenomas or polyps. Now, 85% of colorectal adenocarcinomas arise from conventional adenomas. It may take about 5 to 15 years for these adenomas to transform into malignancy. They undergo series of changes and process that is termed the adenoma carcinoma sequence, which we will see shortly. Now, the risk for these conventional adenomas are sessile adenomas. You know, lesions could either be pedunculated when they are attached to a surface. This is a pedunculated lesion, or they could be sessile like this, okay, attached to a surface. Now, adenomas that are sessile in nature and greater than 2 centimeters, villous pathology, they have higher risk of transformation. Adenomas, usually their histology are 3 types. They could be villous, tubular, or tubulovillous. So adenomas that are villous, sessile, and they are greater than 2 centimeters, have higher risk of malignant transformation. And this may take up to what? 5 to 15 years. Less commonly, the serrated adenomas that present in polypoid forms give rise to about 15% of colorectal cancers. The cancers are usually proximal in location. They are usually proximal in location. The pathway is usually shorter than the adenoma carcinoma sequence. So when it arises from serrated adenomas, it will take less than 10 to 15 years. However, they are less common than the ones arising from conventional adenomas. Now, let us see the adenoma carcinoma sequence. Okay? The adenoma carcinoma sequence, usually, as you can see, we said it takes time, okay, about 5 to 15 years. From a normal epithelium, when there is a loss of APC, adenomatous polyposis coli gene, okay, a tumor suppressor gene, there is initiation of this adenoma carcinoma sequence. And this leads to dysplasia of the epithelium. From dysplasia, after DNA methylation, they will now transform into early adenomas. And activation of KRAS, a gene on chromosome on the short arm of chromosome 12 lead to intermediate adenomas. From intermediate adenomas, when there is loss of DCC on chromosome 18, the long arm of chromosome 18, they transform into late adenomas. And loss of P53, which is also a tumor suppressor gene, at the long arm of chromosome 17, they transform into carcinoma. And from carcinoma, the process of carcinogenesis will occur and these cancers will spread. So if you are asked about adenoma carcinoma sequence, you will say it's a process of transformation of adenomas, benign lumps, into carcinoma. And this process takes about 5 to 15 years. Conventional adenomas are usually involved that are sessile in pathology greater than 2 centimeters and the villous type. And this is the sequence that occur, various sequence from a normal epithelium up to carcinoma and the process of carcinogenesis setting. Now, we've talked about the first pre-malignant conditions, which is adenomas. The next one is polyposis syndromes. You should know that there are several types of polyposis syndromes. Commonly, the familial adenomatous polyposis syndrome is a common polyposis syndrome that is associated with colorectal cancer. It is an autosomal dominant condition, okay? And it's seen on chromosome, the long arm of chromosome 5, segment 2, band 1, okay? It accounts for less than 1% of colorectal cancer. It accounts for less than 1% of colorectal cancer. It is characterized by more than 100 polyps in the large intestine. Now, what are these features? You should know. It is characterized by more than 100 polyps. You will see the image shortly. 75 to 100% of patients develop carcinoma of the rectum and sigmoid at a mean age of 40 years. Now, what you should know about this familial adenomatous polyposis. They usually are seen in adolescents and young adults. Okay? And they transform into carcinoma in about the age of 30 years. And most of the patients will die from this pathology at their early 40s if untreated. And what you should know, it is very important that you know that they have up to 100% penetrance. They have up to 100% penetrance, meaning patients with familial adenomatous polyposis syndrome, okay, 75 to 100% of them will phenotypically present with colorectal cancer later in life, okay? So it's just like a spectrum. Up to about 100% of those patients that have this will present with this malignancy later in life. And they can also present with multiple cancers. And you should know there are various types of variants, which you should go and read up because of MCQs, the component of Gardner syndrome, Turcot syndrome, and Oldfield syndrome. These are all variants of familial adenomatous polyposis syndrome. You can see how the polyposis appear. More than 100 polyps will manifest in the large bowel. Hematomatous polyposis syndrome is also another type of autosomal dominant polyposis syndrome, and you can see various types: juvenile polyposis syndrome, Peutz-Jeghers syndrome, Cowden syndrome, Bayer-Riley, Ruvalcaba syndrome, Crooked-Canara syndrome. All these are hematomatous polyposis syndrome, and they are pre-malignant lesions. You can see this is an image of juvenile polyposis syndrome, which is also a risk factor, not for only colon cancer, but is also a risk factor for gastric and pancreatic cancers. Peutz-Jeghers syndrome. Okay, you can see patient is presenting with a hyperpigmented lesions on the lips. 2 to 3% develop GI and extra-intestinal malignancy. Is the second most common hematoma after juvenile polyposis syndrome. Okay, now hematomas in the upper GI, especially jejunum, this is very important. Why? Because they may present with intussusception. You know, intussusception requires a lead point, especially in adults, where a proximal bowel telescopes into a distal bowel. So these hematomas presenting weight in the small intestine can make patient might present with what? Intussusception. Okay. Now, the skin pigments, melanin, most frequently are what? Perioral or in the buccal mucosa. Now, Cowden syndrome is also another syndromic pre-malignant condition. Okay, and you can see some skin and mucosal lesion in the perioral and around the nasal area. Now, it's not only a risk for colon cancer, but also for breast, thyroid, endometrial, CA, even renal cancers and melanomas. So as we mentioned, all these are pre-malignant condition. To cap again, we said the pre-malignant condition, the first one we'll talk about are adenomas. Okay, we talked about adenomas. We saw the conventional adenomas and the serrated adenomas. We now talked about polyposis syndromes, where we talked about familial adenomatous polyposis, which is the commonest type, and it features and the variants. The juvenile syndrome, Cowden syndrome, Peutz-Jeghers syndrome, all these are part of polyposis syndrome. Now we'll talk about the third pre-malignant conditions, which are inflammatory bowel disease. Okay, inflammatory bowel diseases, ulcerative colitis, and Crohn's disease. Now you should know that ulcerative colitis have higher risk of developing colorectal cancer than Crohn's disease. Okay, ulcerative colitis, pseudopolyp of ulcerative colitis may become malignant if, one, these are the conditions that favors ulcerative colitis transforming into malignancy. The duration of the disease is over 10 years. Okay, the whole large bowel is involved. The disease starts at a young age. The carcinoma is often multiple and 8 times. Colorectal cancer is 30 times commoner in patients with ulcerative colitis than normal individuals. You can see ulcerative colitis is something very important because the risk increased by 30 in patients with this condition. Crohn's disease occur 20 times, have 20 times risk. Now you should know that ulcerative colitis starts from the rectum and ascends upward, okay? While Crohn's disease starts from the terminal ileum and descends downward. So you can see ulcerative colitis tend to be more in the large intestine than Crohn's disease. Hence, it has a higher risk of developing or transforming into malignancy. Okay, now we'll talk about another risk factor for colon cancer. Is what is called HNPCC. This is a very important risk factor for developing colon and rectal cancer. HNPCC, hereditary non-polyposis colon cancer syndrome. Now, the lesions we mentioned earlier on are polyposis in nature, all those polyposis syndrome. But this lesion is a non-polypotic syndrome, and it is what? Hereditary. It is not a syndrome that is associated with multiple polyps. And 5 to 10% of colorectal cancer are due to what? HNPCC. 5 to 10% of colorectal cancers are due to hereditary non-polyposis colon cancer syndrome. It is autosomal dominant in nature and with 70 to 85% penetrance. 75 to 80% to 85% of patients presenting with this syndrome will ultimately come up phenotypically with colon or rectal cancer. It manifests at the age of 44 years. There are two main types: the Lynch 1 syndrome and the Lynch 2 syndrome. These two syndromes are the two types of HNPCC. Lynch 1 is site-specific, which predispose to colorectal only. Lynch 1 is commonly on the what? Right side. Lynch 1 is called colon cancer specific. Please take notes. Lynch 1 syndrome is called colon cancer specific. Why? They present with right-sided colonic tumors. Now, you should know that it occurs in early age, and 40% are metachronous tumors. We'll see what metachronous tumors mean shortly. Now, Lynch 2, on the other hand, is called cancer family syndrome. Okay? We said Lynch 1 is colon cancer specific. Lynch 2 is cancer family syndrome. Why? They are associated with other malignancies. So they are termed cancer family syndrome. Okay? Patients or their family develop colorectal, ovarian, breast, endometrial, stomach, proximal urethra, or biliary tree carcinomas. Okay? They are associated with other multiple malignancies, so they are called cancer family syndrome. Now, There are some diagnostic criteria you see in a patient before you say they have HNPCC. There are some diagnostic criteria. This criteria you should know. There is the Amsterdam criteria, the modified Amsterdam criteria, and the Bethesda criteria. The Amsterdam criteria. Now you should know, for Amsterdam criteria, at least 3 relatives, okay? The 3 of the relatives of that individual should have a common cancer, okay? Now, one affected person is first-degree relative of the other 2 affected. 2 successive generations of that family must be affected, okay? And at least one of the colon cancer diagnosed before the age of 50 years, okay? So when you see cancer in younger individuals, less than 50 years, look for other features of hereditary non-polyposis colorectal cancer. And you should know FAP should be excluded. Familial adenomatous polyposis syndrome should be excluded because we said HNPCC is a non-polyposis cancer. So 3 relatives should be affected. 1 should be a first-degree relative with the other 2. 2 successive generations should be affected. Patient affected should be less than 50 years, and FAP must be excluded. Now, there's a modified Amsterdam criteria, okay, which is the same as Amsterdam, except cancer must be associated with HNPCC, okay, colon, endometrial, small bowel, and others, instead of colon, specifically colon cancer. Tumors should be verified by pathologists. Now, this is other criteria, the Bethesda, which you can also review later. So, the next risk factor we'll talk about is diet. The next risk factor we'll talk about is diet. What are the diets that are risk for developing colon cancer? Red meats. You should know high intake of fat, saturated fat, increase the risk of colorectal cancer. Saturated fat increase the tumor promoting arachidonic acid and its metabolite on the cell membrane. So this tumor promoting arachidonic acid that is derived from the breakdown of saturated fat are carcinogens. That is 1. You should also know that increased fat in our diet enhance the activity of anaerobic organisms. And what does this anaerobic bacteria do? They break down primary bile acids, which are cholic acid and quinodeoxycholic acid, into secondary bile acid, litocholic and deoxycholic acid. Now, these secondary bile acids are what? Carcinogens. Litocholic and deoxycholic acids are carcinogens, and they are risk for colon cancer. You should note, saturated fats increase risk of colon cancers. 1, by generating tumor-promoting arachidonic acid. 2, by enhancing anaerobic organisms, proliferation of anaerobic bacteria that breaks down primary bile acid into secondary bile acids. And the secondary bile acids are carcinogens. Now, what are the diets that are protective against colon and rectal cancer? What are the diets that are protective against colon and rectal cancer? Fiber diets, vegetables, fruits, whole grains, calcium, vitamin A, C, E, zinc, and fish are protective. Fruit and vegetables depresses the fecal bacteria enzyme activity and thereby reduces the concentration of fecal bile acid. So this fruit and vegetable reduces the concentration of fecal bile acid, and there is a positive association between colorectal cancer and the level of fecal bile acid. High fecal bile acid is correlated to what? Adenoma size, okay, and the severity of epithelial dysplasia. You should know the higher the fecal bile acid, the higher the risk of colorectal cancer formation. When you take fruits and vegetables, it reduces the amount of fecal bile acid. You should also know calcium combined, it chelates the bile salts, reducing bile salt concentration in the colon. So calcium also acts on the colon mucosal cell to reduce proliferative potential. So you should know high fiber diet, high calcium containing diet, vitamin A, C, E, zinc, and fish. These are protective against colorectal malignancies. Now, exposure to radiation. Radiation treatment of prostate cancer, okay, moderately increase the risk of rectal cancer in radiated sites with time. And the type of cancer they produce is mucinous adenocarcinoma. Surgeries like cholecystectomy, ileal resection, what do? They increase circulating bile in the intestine, which will increase fecal bile acid, secondary bile acid, which will also increase risk. Now, retrosigmoidostomy is a form of urinary diversion where the ureters are anastomosed with the sigmoid and the urine is passed through the rectum. Retrosigmoidostomy increases the risk by 100 to 500 times. After cholecystectomy, ileal resection, there is increased bile salts, which is carcinogenic. Now, lastly, before we go, we are going to talk about the pathology of colorectal cancer. You should know macroscopically there are 4 types of colon cancer that are summarized as CUTA: cauliflower, ulcerative, tubular, and annular. Cauliflower, ulcerative, tubular, and annular. What you should know is the cauliflower and ulcerative type are usually seen in the right side of the colon. The tubular and the annular type are seen in the left side of the colon. Now, what you should also know, cauliflower and ulcerative seen in the right side, they rarely cause obstruction. Tubular and annular seen on the left side, they commonly cause obstruction. You should know right-sided colonic cancers present with non-obstructive symptoms. They present with the 3 A's of malignancy. The right-sided colonic tumors present with 3 A's of malignancy: anorexia, anemia, and asthenia. The left-sided colonic tumor present with features of intestinal obstruction because they are what? Circumferential. They are tubular and annular, so they tend to obliterate the caliber of the lumen. Cauliflower or proliferative type is a bulky fungating tumor which projects into the lumen of the gut. As it grows, it may become necrotic and ulcerate. They are usually tumors in the right side. So before they grow to cause obstruction, they ulcerate, okay, and become the ulcerative type. The ulcerative type has raised, irregular, everted edges and sloughing floor. It grows in the transverse axis of the bowel, commonly on the right side also. Now, annular is stenosing, commonly on the left side. It is circumferential and less than 5 centimeters, present with intestinal obstruction. The tubular or infiltrative, when annulally spread longitudinally to involve a segment greater than or equal to 5 centimeters. So you should know, as we mentioned, right-sided are cauliflower ulcerative and left-sided are tubular and annular. Now, you should remember, right-sided colonic tumors do not present commonly with intestinal obstruction because of 3 reasons. Left-sided colonic tumors present with obstruction because of 3 reasons. Right, left. Now, they uncommonly present with obstruction. 1, because of the nature of the tumor. They are cauliflower and ulceratives. They are unlikely to present with obliteration of the lumen. 2, the size of the right side is larger. The diameter of the colon on the right side is bigger than the diameter on the left side. So the colon progressively reduces in size from the cecum to the sigmoid colon. So there is progressive narrowing of the caliber of the colon, because you see the cecum, the size of the cecum alone is about 7.5 to 8 centimeters, 8.5 centimeters, and these progressively reduce. So you have smaller caliber, larger caliber, sorry. You have a larger caliber. And thirdly, the consistency of the stool in the right side is liquid. Now, the reasons why the left side presents with obstruction: 1, the nature of the tumor is tubular or annular, which is circumferential like a ring. 2, smaller caliber. And lastly, the consistency of the stool there is solid. So you should know that 5 to 10% of colon cancer are synchronous and 10 to 20% are metachronous. Synchronous tumors, when you say synchronous tumors are multiple primary tumors as different parts of the colon at the same time. When a patient presents with colon cancer, and at the time of presentation, there are multiple tumors at different parts, all these tumors are called synchronous tumors. Or when a primary tumor presents and later you notice another one, but in less than 6 months, you can also regard them as synchronous tumors. Metachronous tumors, these are growth in different parts at different periods. And this period should be greater than 6 months. So you regard them as metachronous tumors. So the histological types, 90% are adenocarcinomas. 90% of colorectal carcinomas are adenocarcinomas. They could be mucinous adenocarcinomas, sigmoid ring, small cell, old cells, okay? They are rare with poor prognosis, squamous cell, or undifferentiated. So today, we are able to see the epidemiology of colon cancer. We are able to describe the anatomy of the colon, the relevant anatomy of the colon and rectum. We are able to discuss the risk factors for colon cancer. And lastly, we mention the pathology for colon cancer. So we are going to stop the lecture for today, and we will now entertain question and answer. So for now, I'm going to allow you to unmute yourself. And if you have any question, you can unmute yourself and ask. Then we will now entertain the question. Thank you very much. If you have any question, you can unmute yourself and ask. Then we respond to your question. Thank you. Any question? Any question?
Yes, sir. I have a question.
Okay, you can go ahead.
Thank you for the presentation. The question that I wanted to ask, that ureterosigmoidoscopy, what is in the urine that increases the risk of colorectal cancer by 100 to 5?
Okay, that is a very good question. He asks, even though your network is not clear, but what I can pick from the question is what is in the urine that in ureterosigmoidostomy that increases the risk of rectal cancer to about 500 to 1,000 times. Now, you should know when the ureter is connected to the rectum, okay? The urine continuously flow into the rectum. The urine continuously flows into the rectum, okay? And there is dysplasia of the epithelium of the rectum. Because of that bypass and continuous drainage of urine into the rectum, it causes epithelial dysplasia, metaplasia, and transformation. And the type of cancer that is common in such condition is a squamous cell carcinoma. Unlike the usual, we said up to 90% of cancers are adenocarcinomas. Now, it's because of the chronic irritation, okay, of the rectal mucosa or the sigmoid colon mucosa from the continuous flow of urine that causes dysplasia, and from dysplasia, metaplasia, and from metaplasia, transformation into malignancy. I hope that is clear.
Yes, sir. It's very clear, sir. Thank you, sir.
You're welcome. So any other question? If you have question, please, you can unmute yourself and ask.
Yes, sir, I have question.
Okay, you can go ahead.
Firstly, sir, I want to thank you for the wonderful presentation.
You are welcome.
Thank you very much, sir. So my question is that with regards to the epidemiology,
Yes.
between we the Africans and the Western world, which type, histological type of the colorectal carcinoma the Africans do usually developed as compared to the Western one? Like, is there any preference with regard to the regions, the Africans and the Western world? Which one of the histological type we the Africans tend to present with it more? While in the case of the Western world, also which histological type do they commonly present with?
Okay, that is a very good question. Now, you should know generally, most of the colon cancer, rectal cancer, whether in the Western world or in the African sub-region, most of them, up to 90%, are adenocarcinoma. Now, the 10%, whether in the Western world and in the African region, are uncommon.
Okay.
Now, even the adenocarcinomas have different types, okay? But generally, it is the adenocarcinoma that most of the colon cancer, it is the adenoma that predominates, whether in the Western world or in the African region. When you start seeing some variants, okay, there might be some specific causes. For example, we mentioned the ureterosigmoidostomy, where it's giving rise to what squamous cell, because that is arising from a chronic irritation. Do you understand? But all
Yes.
others are adenocarcinoma.
Yes. And so I have another question.
Yes.
So with, how will constipation be related to colorectal carcinoma?
Now,
Constipation.
the feces have carcinogens.
Yes.
The feces have carcinogens.
Yes.
Now, these carcinogens, as we mentioned during the lecture, fecal bile acid correlates with cancers. The higher the fecal bile acid, the higher the cancer. So when the feces stays longer in the colon, the contact of carcinogens with the colon mucosa is higher, so they tend to have higher risk of cancer. That's why the high fiber diets that increase the transplant will be a factor that reduces the risk for colon cancer.
Yes.
The more the constipation, the longer the contact of carcinogens with the large intestinal mucosa.
Yes.
Hope it's clear.
Yes, sir. It is very clear, sir. Thank you very much.
Okay. Any other questions?
So the final question I have.
Okay.
Although maybe, yes, among the histological type, which one has the worst prognosis? I don't know.
Okay. Now, usually, when you have undifferentiated carcinomas, they have worse prognosis. Why? Because they are, when all the uncommon types, usually undifferentiated type, they usually have worse prognosis, poor response to treatment, than a well-differentiated carcinoma, even though sometimes an undifferentiated will respond to chemotherapy. But usually, those uncommon types that forms about 5 to 10% of the cancers are the ones that have poorer prognosis and worse type to treat, and they are very difficult to treat. So the undifferentiated types are the types with poorer prognosis.
Thank you, sir.
Any other question?
Yes, sir. Hello.
Yes, you can hear.
Hello, sir.
Yes, go ahead. We can hear you.
Okay. Thank you very much for the presentation, sir. So my own question is that does colorectal cancer has any gender predilection, or is it common for the incidence is common in all for both sex, or it has any gender predilection?
Yes, we mentioned that in the introduction that the colon cancer, the incidence of colon cancer is about 10% in male and 9.5% in females. But generally, colon cancers tend to be commoner in females, but rectal cancer are commoner in males. But all in all, the difference is not more than 1%, but the incidence is about 10%. 10 in males, 9.4 in females.
Okay.
Hope that is clear.
Thank you very much, sir. Yes.
Yes, any question? Okay, let's take the last question. Okay, it appears there's no any other question. So we are going to stop here. Then subsequently we'll continue with the staging, clinical presentation, and then diagnosis of colon cancer. Thank you very much for participating.
Thank you, sir.
Thank you, sir. Thank you very much, sir.